Good afternoon and welcome to this CAQH Explorations webinar in which we will provide an overview of the findings of the 2015 CAQH Index Report. My name is Karen Waller. I'm the Director of Communications and Marketing at CAQH and I'll be your moderator today. First, a few logistics. Today's session is being recorded and following the webinar, all attendees will receive a link to view the webinar or share it with your colleagues. Your phones will be muted during the presentation portion of our webinar. There will be a time for questions at the end of the presentation today. You may submit your questions at any time by typing them into the questions panel on the right-hand side of the GoToWebinar display desktop. We will also take a few questions by phone after the presentation. So when directed, just press the Raise Hand button to join the list of individuals with audio questions. Next, I'd like to introduce today's speakers. Gwen Lowe's is Deputy Director of CAQH. Elizabeth Ormson is a Senior Statistician at NORC at the University of Chicago. And Reynard Washington is Senior Manager of Research and Development for CAQH. Gwen will begin the presentation with an overview of today's agenda. Gwen?
Great, thanks Karen, and good afternoon everyone. Thank you for coming on today's call. We have a wide variety of folks on, so we are going to give a quick overview of CAQH, talk about what the index is, and then really dive into the findings of this year's report, both from, you'll be hearing from our Director of Research and Measurement, and then also for the consulting firm that works with us on the provider numbers. You'll hear the call to industry to action, and then the future focus. And then we're going to, as Karen had highlighted, make sure that we have time for questions at the end, both those that submitted at the registration and if you type them in, and we'll open up the phone. So if we go to the next slide, for those of you that are not familiar with CAQH or only familiar with it in one way, we are a nonprofit alliance focused on streamlining the business of healthcare, and we do that through initiatives that deliver value to providers, patients, and health plans. And you'll see the list of initiatives here. Many of you that are registered work with us on one or many of these initiatives, and some of you had questions that pertain to some of the other initiatives. You'll see that there's an email later in the presentation. Feel free to email us if you have other questions, and we will be sure that someone does get back to you. If you do want to know about any of these other initiatives, I highly encourage you to look at our website, or we can send you additional information and speak with you offline. Everything from a coordination of benefits registry, which you'll see on the top of at COB Smart, to our operating rules, initiatives, and the certification it offers out, Direct Assure, which is a provider directory product that just launched, and many new entities are using that product. Enroll Hub for EFT and ERA, which is a key component of driving the index. And the index itself, and ProView, which is a provider data collection tool, and there's over 1.3 million providers in ProView and nearly 800 entities, health plans, and hospitals that are accessing that. And for all of these initiatives, there's a significant market support and involvement on a multi-stakeholder level, so we do hope that you do get involved, including on sanctions track, which is part of ProView. We go to the next slide, why the index and what it is. The index is the only industry source that's tracking on an aggregate level full adoption of electronic transaction and establishing benchmarks for both the volume and the cost. And without that type of tracking at an aggregate level, we really can't, as an industry, identify specific opportunities and further improvement. The index has been really working across both health plans and providers and those vendors that support them to figure out how do we track adoption, and are the systems in place to do that tracking and report it publicly. It is guided by an advisory council, and if you go to our website, you can link onto the names of the advisory members, but there's a wide variety of experts on that to help us during the process for the data analytics, the focus of the data collection, and also the analysis and the action to make sure they fit into the broader context of the industry. And we as CAQH, given our mission and vision, are committed fully to evolving the index. So we want to hear from you all. What else do you want to see in the index? And you'll hear later a discussion about that. Where do you think it needs to go? What else should it include? And we want to involve you in that conversation now, but also you'll be hearing from us later in the year, because this tool is for industry and by the industry. So getting your views on how it needs to evolve is essential to keeping it useful to your daily businesses. Why does the index matter? I think we're all familiar with HIPAA, which was hard to believe over 2 decades ago. You know, even though that is 2 decades ago, we're still really using manual processes for a lot of these basic transactions. And at a minimum, reporting out the results is helping us as an industry to realize we need to do better, and we need to work together to do better. And not only report that out, but then push adoption on things that do exist, best practices, so we can really have electronic real-time transactions to support what needs to be a modern healthcare system. There's significant industry costs that are unnecessary. Some estimate up to $31 billion for the healthcare providers sending these transactions, and that really is an unneeded cost to what is already a costly healthcare system. So reducing that administrative burden, letting the providers and the health plans focus on the things that they really need to worry about, not the administrative piece, and then combining our work and complementing what's happening in clinical. We're all familiar with what's happening with meaningful use and EHRs across the board. Our administrative side should directly complement that and get the provider and the patient what they need at the time they need it. So with that, I'm going to hand the presentation over to Raynard Washington, our Senior Manager for Research and Measurement, and he's going to go through the details of the report.
Great, thanks, Gwen. So as Gwen said, the index is an annual survey of both commercial health plans as well as healthcare providers. For health plans, we include, so first I'll orient just a little bit to how the index, we collect the data and what we do to it, as well as then we'll talk about the adoption rates, and then we'll talk about the cost estimates and cover our industry call to action. For health plans, we include individual and group coverages as well as coverage through the exchanges, as well as managed Medicare and Medicaid through commercial insurance companies. And based on estimates from the AIS annual survey of health plans, we estimate that about 45% of the commercially covered lives are included in our sample of responding health plans. Of note, we have observed a significant increase in the enrollment over the 3-year study period for the plans that have participated all 3 years. Also, for the first time, I will add that we are reporting adoption rates for the dental health plans. This year's respondents represent also about 45% of the those with commercial dental insurance. And so we're really excited to be able to report both now medical and dental and have a very large representative share. Just to give some context, we analyzed nearly 5 billion transactions across both the medical and dental plans. So it's a relatively large and very robust set of data. We partnered with NRRC at the University of Chicago to manage the healthcare provider component, which Elizabeth will give some details about what happened on the NRRC side later on in the presentation. If we go to the next slide, you'll see that CAQH has really continued to evolve the robustness of the data in the index over the life of the index. We've had the index for about 3 years now, and so we've tried to every year add and make our estimates more precise, as well as add some new components to be able to inform what's happening in the industry as it relates to adoption of electronic transactions. At this time, we currently seek to collect information and about adoption and costs for all of the HIPAA standardized transactions. And what you'll see on this slide are the transactions and their applicable HIPAA standards, and as well as a notation whether or not there's a mandated operating rule for the standard, or sets of operating rules, excuse me, as well as a description of what the transaction is. And the last column shows you what year we added to the index. And what you'll see here on this first slide is this first 6 transactions that we began tracking in 2012 when the index first began. On the next slide, you'll see the other transactions that we have added over the years, for which this year we have added some additional transactions for which we'll be reporting detailed findings about coordination of benefit claims for the first time, as well as referrals. And so we're really excited, and you'll see there listed all the transactions that we actually asked for from our participating plans in the survey. So now we'll begin with the adoption estimates. The next slide. As an overview, participating health plans report detailed volumes of administrative transactions by product line as well as by method. We classify the transactions by method in 3 categories. The first is fully electronic. This only includes transactions between health plans and the healthcare providers that are conducted electronically using the HIPAA standard that I just showed on the first 2 slides. Secondly are the partially electronic transactions. These are unique in that they're transactions that are conducted via health plan-sponsored web portals or interactive voice response systems, which are systems where you interact with a voice via telephone, an automated system via the telephone. These are deemed partially electronic because they require more human interface for the healthcare providers, but don't necessarily require human interface for the health plans. The last category is the fully manual category, which basically includes the transactions that require end-to-end human interaction to complete, which are telephone calls, faxes, as well as postal mail. Next slide. So this slide actually shows the adoption of fully electronic transactions across all the transactions for which we report detailed findings. The blue bar actually indicates the latest adoption rates for 2015. The darker and lighter gray bars show the trend over time for 2012, 2013. As you can see, there has been steady, modest increase with some accelerated growth for some of the transactions in the rate of adoption for fully electronic transactions. I'll also note here that there's some variation across the transactions in terms of adoption. Claim submission has a very high adoption, which is near 94%, while some transactions like prior authorization and referrals have pretty low adoption with less than 10%. So I'll continue to go forward and cover some additional details about each of these transactions. That provides for you just a high-level overview of where we are with all the transactions. Again, claim submission continues to have the highest adoption rates. It's important to note that some health plans, including CMS and other providers, currently require providers to submit claims electronically. And we speculate that this may be driving this near full adoption for claim submission. It's also important to note that adoption rates were similar for both individual providers as well as facility providers. And so we do get a breakout from the plans whether or not the claims were submitted from an individual practitioner or from a facility. And the adoption rates are very comparable across the 2 categories. This is the first year that we've been able to report adoption for coordination of benefits claims. About half of the COB claims were submitted electronically utilizing the standard that I described earlier, or we displayed earlier. Given the complexity of coordination of benefits, the overall process, we really highlight in the report the need for increased coordination among plans as well as providers, and even with members, to use innovative solutions to really further try to streamline the COB process to be able to identify and increase capability to detect and coordinate COB before claims are submitted and before the patient actually receives care. Move to the next slide. We saw a significant increase in the volume and rate of use of fully electronic eligibility and benefit verifications, as well as claim status inquiries. Of note, for both of these transactions, there were a significant increase of about 5% for eligibility and benefit verifications and nearly 7% for the claim status inquiries. These increases corresponded to, like I said, very large increases in volume of electronic transactions for both of these transactions. Of note, though, we also saw a relatively stable level in the volume of manual transactions for both of these transactions. We may have anticipated a noticeable decline in the volume of the fully manual that corresponded to the increase in the volume of electronic use, but we did not observe that. While more work is really needed to understand the exact factors and understand this correlation between increasing electronic and seemingly stable manual volume, several factors may actually be influencing this increased use of electronic transactions. This includes, for one, as the volume of claims increase and the volume of covered lives increases, you might anticipate that there will be more eligibility and benefit verifications, and the volume of these transactions may increase. This further supports the need for benchmarks, which is one of the things that the index works to provide for the industry of the number of transactions we might anticipate per member, per claim on an annual basis. Also, the ACA mandated operating rules were effective for these transactions during the study period. We saw a more rapid increased use of the electronic transactions in the second year following the implementation of the operating rules, which may indicate that as the industry has a time to uptake and comply with operating rules, that we would see increased use of the electronic transactions. Also, the vendors continue to offer products, practice management systems that routinely check a patient's eligibility as well as claim status with the health plans on a regular basis, whether or not the patient is presenting for care or whether or not the claim was recently submitted. And so those practice management systems obviously would continue to drive the volume of these transactions that we would see as they're interacting electronically with the health plans. Continuing forward, as noted earlier, electronic adoption for prior authorization and referrals are really low. It's important to see here that web portals are actually the predominant method for conducting both of these transactions. Additional efforts are obviously needed to drive utilization of the HIPAA standards for these transactions, and we continue to work with our plans to be able to identify opportunities to further understand what's happening in the market as a result, as it relates to use of prior authorization and referrals. The estimates for referrals included in the report only represent a subset of the plans. We continue to work with all the plans to be able to try and provide the estimates for the adoption of referrals. And we anticipate that we'll be able to facilitate reporting in future years from all of our plans. As we have worked this year to learn about some of the barriers to being able to collect and track these data. Continuing forward, adoption for EFT and ERA are about 60 and 50% respectively. We observed some increases in adoption of electronic for both of these transactions, but it may not have been as dramatic as we might have expected, given all the industry activity that's happened around these two transactions over the last couple of years, last few years actually. This includes the ACA mandated operating rules were effective during this period. Also in 2013, as you may know, CMS began requiring providers to enroll in EFT payment, as well as the availability of several industry solutions to be able to increase provider enrollment and also streamline provider enrollment into EFT solutions and options. That said, we might expect to see more marked increases in later years. The 2016 report will, of course, reflect the activity that happened or data for 2015. So we anticipate that maybe in future reports we'll see a more marked increase, as we did with the eligibility and benefit verification and claim status increase. Moving forward. With the enrollment and disenrollment premium payment, this is the first time we have actually sought to collect these data from our plans. We included this in the data collection tool for the health plans for the first time. Based on the response from a subset of plans, I'm happy to report that it does seem that the HIPAA standards for these transactions are being used, and in some cases at a very high rate. We are unable at this time to report detailed estimates for this year due to our commitment to our plans to ensure data privacy for our respondents. We have noted some barriers here on this slide for reporting that were reported by our plans, and we are at CAQH, along with our advisory council, along with our data contributors, working to actively address some of these barriers and hope to be able to report additional detail for both of these transactions in 2016. Great, so on to dental adoption. We are very excited for the first time to report data from the dental health industry. As you can see in this table, which reports the fully electronic adoption of fully electronic transactions for the dental community, it lags significantly behind the medical community for the transactions that we're able to report this year. The differential between dental and medical ranges quite a bit, being as low as a 17 percentage point difference for claim submission to as high as a 55% difference for EFT adoption. We are working actively with our partners in the dental community to be able to obviously increase awareness about this data, as well as to work to identify ways that we as an organization can collaborate to further drive adoption. On the next slide, we actually show the distribution across methods for the dental industry for the 4 transactions that we're covering, which is claim submission, eligibility and benefit verification, as well as claim status and EFT. And as you can see for this, specifically for some transactions, the eligibility and benefit verifications as well as the claim status inquiries, the adoption in 2014 of web portals and IVR systems was much higher than it was compared to the medical industry. So it seems that there may be increased usage of these for the dental plans. And as a reminder, the dental plans we have are covered a fair bit of the dental industry, so we're excited that we're able to have a representative sample here. Okay, with that, we're going to move to the cost estimates. I'll turn it over to Elizabeth from NORC to present the results of the healthcare provider survey.
Hi. So just to give you a little bit of background about NORC, we're in our 75th year of being around, which is a huge accomplishment. We are primarily a survey research institute associated with the University of Chicago, and we tend to work on a multitude of different surveys, a lot of them government initiatives. In particular, we work on two very large surveys, National Immunization Survey for CDC and the Medicare Current Beneficiary Survey for CMS. So for this survey, even though we deal with a lot of healthcare type stuff, we don't deal as much with the payment type process. So this is a really interesting survey for us to get involved in as well. For the data collection, we wound up working with CAQH in trying to identify not only people who had responded in the prior year, but working and seeing what connections CAQH had, what connections NORC had, and then also working with the connections that Milliman had been able to recruit last year. So from that, we had this targeted outreach both through email and phone, as well as an initial webinar that was created last spring to try and get people engaged in completing the survey. Through that, after that, once we had done that initial outreach, then we actually wound up doing a large email blast to approximately 250,000 providers that also yielded some people who were engaged and interested in the project. During data collection, the providers could actually respond either through an Excel sheet that we had pulled together or an online tool that we had developed with CAQH, and to try and get that, hopefully streamline some of the information and help us understand, where people were having problems in terms of gathering data. And so some of the information that we were primarily getting after to create these cost per transaction estimates was the staffing in terms of the number of employees that were actually working on specific transaction types, and then the salaries associated with those employees. Additionally, we were also interested in the transactions themselves, so the volume of transactions, both in terms of the type of transactions, as Reynard discussed earlier, but then also by mode, obviously electronic versus manual. And then we are also looking for not only the volume of those transactions, but the percent of time that their employees spent processing each of those transaction types by mode. There were also some other questions that were asked that didn't actually impact the cost per transaction, but we were trying to get some understanding of some things such as, what are the hurdles to try and get some of this electronically done. So on this page, we kind of give you an overview of the types of providers that we were able to engage, both in what Milliman was able to engage in 2014 versus what we were able to engage. And you can see that first table is the average monthly transaction volume, and this is across all transaction types. And so you can see in 2014, they typically had much larger providers responding, and we had much smaller ones. And that's what the two at the bottom represent. We categorized groups of monthly transaction volumes, and you can see, again, the 2015 responders we had quite a few that had less than 10,000 transactions per month, whereas the 2014 respondents had a wide range, both from under 10,000 to 1 million transactions per month or more. During data submissions, we tried to review the data as it was coming into us, so that way if there were any questions or any follow-up that we needed to do, we could contact the the respondent as quickly as possible. And so what we did is we looked at information both from 2014 as well as whatever had come in at that point for 2015, and tried to look and see, okay, were the values that people were putting in, were they reasonable? Did they seem, you know, they sort of passed the sniff test, if you will? And if they didn't, we try to go back to the respondent and try to get some further information, make sure that either the information was correct, or no, they'd actually inadvertently put something else in that wasn't what they meant. After data collection, there were a couple of respondents where there was maybe some incomplete information, and so we wound up removing some of those on a transaction basis. Prior to creating the estimates, but after data collection was complete and all follow-up had finished, we did a few more data cleaning steps just to make sure that our data quality was as good as possible, and tried to detect any extreme outliers. So we looked at three things in particular, but where we created some volume thresholds so that any respondents that had extremely low volumes were removed for that transaction. Because there were some providers that had very few instances of certain transaction types. There were also instances where there were a lot of FTEs reported processing a given transaction type, but based on what we were seeing from other providers across 2014, 2015, this didn't quite make sense. So we created thresholds for the number of FTEs based on the transaction volume. And then lastly, where there was a discordant amount of percent of time spent on a certain transaction type versus the amount of volume, we removed those as well. And so what it's talking about here is where somebody says only 5% of their transactions in terms of volume are electronic, but they're spending 95% of their time processing the electronic transactions, which obviously doesn't quite make sense. So those were sort of all the data cleaning steps that went into creating the actual weighted estimates, and that was based on 5 steps. And I should note here, we combined both the 2014 and 2015 respondents together and took out any duplicate cases. I think there were 1 or 2 cases where we had a respondent from both years, and so we just took 1 year of that respondent's data. So the first step was to create monthly salary costs based on the average salary that had been reported, as well as the number of employees. And that was by transaction type. The remaining steps were done by transaction type and mode, the mode being manual versus electronic. And each of these are within the provider. So the first step was to create an estimated monthly salary cost, and this was based on the percent of time that the provider reported spending on either manual or electronic processing. Then we estimated a fully loaded monthly salary cost, and this was based on loading factors from MGMA for manual processing versus electronic processing. And then the fourth step was to create a provider level cost per transaction. And then the last one was, and so this was for each provider, we created that cost per transaction type. And then the last step was to combine across all providers. And so to do that, we weighted these individual costs per transaction based on the relative volume for each provider across all providers. The weights, when we looked at it, obviously, as we noted earlier in 2014, there were some very large providers that we had, and so we kept the weight so that way there wasn't one individual provider who was dominating the overall cost estimate. And then lastly, the weighted estimates for each provider were then summed across all providers to get that final estimated cost per transaction. And so the next slide shows the transaction types and then the estimated provider costs for both manual and electronic. And as we would expect in general, you know, across the board here, manual costs are more than electronic costs, but there's quite a range in terms of the differential between them. If we look across all 6 of these transaction types, the average difference is about $2.2. But you can see, prior authorization and eligibility and benefit verification have much wider ranges between the manual and electronic estimates. But I do want to note that there were some limitations here. The year-to-year differences that we do see between 2014 and 2015 probably don't reflect a true trend in costs over the years, but probably caused more by variation due to 2 things in particular. One, we had small sample sizes both for 2014 and 2015. And then, again, as noted, the composition of the respondents for the 2 years was quite different, with 2015 having smaller providers than 2014. And so with that, I will turn it back over to Reynard.
Great. Thank you. So I'll say that similar to the healthcare providers, the health plans use a variety of internal reporting systems to estimate the fully loaded costs to plans for each of the transactions. Different from the providers, health plans also integrate vendor costs directly into the estimate based on their internal financials that they have available to them. And I'll just remind everyone that the data that we report today actually reflects the data year 2014. So this is the 2015 index report, but the data that we collect actually reference 2014. So we ask our participants, the respondents, to report based on their estimates for 2014. The next report that will be released later this year, the 2016 report, will reflect the estimates for 2015. So as I was saying, for the health plans, we also use a similar approach and strategy to estimate the health plan cost per transaction. And we also use a similar weighting strategy where we weight based on the size of the health plan as well as the volume of the transactions to be able to produce estimates both for manual and electronic transactions. So to the next slide. As you can see here, similar to the healthcare provider estimates, manual processes consistently cost health plans much more than the electronic processes, and also on average about $2 more compared to the electronic processes. There is, of course, some variation across the transactions, with the largest per transaction savings really being for eligibility and benefit verification for health plans, which is different than the healthcare providers, where the prior authorizations were the most expensive, where there was the largest cost differential or potential cost saving from adopting electronic. And the same is true for claim status inquiries for health plans, where you have about a $4 difference per transaction. So a claim status that's inquiry that comes in via telephone is $4 more than a request that's received electronically. Next slide. So what we've done on this next slide is basically combined all the estimates from both the healthcare providers as well as from the health plans as a single transaction cost for both entities. The industry, and as you can see, what the industry stands to save on average for each of the transactions. If you combine the health plan and provider costs, again, reminded that for every transaction that happens, there's costs for the health plan and there's costs for the provider. So any individual transaction actually costs the industry the combined cost for both the healthcare provider and the health plan. And so the savings opportunities is the combined of the two. So it's more than $4 differential on average across the industry costs for electronic versus manual. And again, the largest savings and opportunities that we have on the per transaction basis are for the eligibility checks, the claim status inquiries, as well as for the prior authorizations. Where in those cases, the cost differential is upwards for the industry towards $8 to $10 per transaction. So we utilize these per transaction cost estimates in tandem with the extrapolated volumes, the estimates of volume for the industry. So basically what we do is we take the volume of transactions that we receive from the health plans and we extrapolate based on the proportion of the health plan that's represented in the index. And we basically extrapolate the volumes upward, and then we multiply the manual transactions that we estimate in the whole industry by the cost savings opportunities per transaction on a transaction basis to be able to estimate how much the industry could potentially save by fully adopting electronic processes for these transactions. The details of the methods are further outlined in the report, and we're happy to further discuss this later answering questions. But we estimate that the industry could save over $8 billion annually by fully transitioning to electronic transactions. And of course, these estimates are based on the data we received in 2014. And so as the industry continues to increase the volume of transactions, we increase the number of covered lives, this number only goes upwards. And it's also important to add that this only reflects the cost savings that we estimate related to the commercial insurance industry. So it does not actually include, for example, CMS and the Medicare program, because we don't actually have them included here. And so while the index is working to include additional comparative estimates from CMS, this is just only at the tip of the iceberg, in that we're only accounting for the cost savings associated with just these 6 transactions, and not all the transactions, and it's only for the commercial health insurance industry. So there's obviously huge saving opportunity. And I'll just highlight that the largest saving opportunity for us obviously is with eligibility and benefit verifications, which we have anecdotally heard from our health plan participants that there's huge saving opportunity for the industry if we can reduce the high volume of telephone calls related to eligibility and benefit checks. We will be a huge cost savings on an annual basis to the industry. These findings demonstrate for us and the industry that there's an urgent need for action. While the industry has made significant progress, we believe the transformation is really far from complete. While the true ideal of having full adoption may not be a reality at any point for the industry, we do believe there's a huge opportunity here to make further progress forward. So based on these findings, we have outlined very specific recommendations with the support and input of our advisory council, as well as based on the data that we have collected here, as well as based on input from our participating health plans. And I will tell you that the advisory council is composed of both representatives from the health plan industry, the vendor community, the healthcare providers, and so it's really a multi-stakeholder and has the perspective of many key components of the industry that actually supported these industry recommendations. The first of these recommendations is the need to share and expand best practices to increase adoption among stakeholders. This really includes the need for industry as well as government-led outreach and education to all stakeholders. That includes health plans, healthcare providers, vendors, about the need to adopt, as well as about the best practices to be able to make the transition from manual to electronic processes. We've seen with other initiatives that this has been an effective outreach. Effective outreach can make a huge difference with penetration. Next, we believe that it's necessary to assess existing federal regulations and strategic plans to ensure that they are really sufficient to support the rapid adoption of these automated processes. While we can't specifically attribute adoption improvements to regulations, it should be considered if institutionalizing some level of adoption for all stakeholders beyond health plans and their agents might be necessary to further drive adoption here. This might also include some mechanism for proactive enforcement compared to the sort of passive enforcement system that we currently have in place. Additionally, we also highlight in the report there's really a need to coordinate among federal agencies around strategic plans for health IT. And the plans really should consider the availability of market resources for both adoption of new clinical initiatives as well as new administrative initiatives, as well as plans for integrating the adoption of both clinical and administrative initiatives around health IT. And really the introduction of these initiatives in some strategic incremental fashion so that the system itself doesn't get overloaded by the sort of the high demands for change. Thirdly, reducing adoption barriers for all stakeholders, we believe, is very critical to the obviously driving adoption for the industry. We propose the consideration of incentives or contract options to address the initial investments that are needed for both providers and plans to be able to adopt systems that are able to support these automated processes. Also, we think it's important to highlight the need to really engage the vendor community in this process. Vendors are not currently required or mandated at this point to utilize the standards or the operating rules. And so we believe that engaging the vendor community outreach, targeted education for that community to actually encouragement to provide and support practice management systems for our healthcare providers that integrate these processes into the workflow readily is critical to being able to ensuring we would truly drive adoption in an efficient and rapid fashion. Fourthly, we also recommend that there be continued systematic review of the transactions, the standards, the operating rules, as well as all regulations that surround them, to be able to understand whether or not they are meeting the needs of the industry, understand whether or not they're meeting the needs of both the health plans, the healthcare providers, their agents, and also to be able to establish some regular cycle for maintenance so that we are assessing whether or not we're maximizing our efficiency, we're maximizing our cost savings. That is critical, we believe, to ensuring that we have sustained impact as the industry continues to evolve. And lastly, we need to really keep tracking and do more tracking. Monitoring this transition, as Gwen mentioned earlier, is really, really important and provides valuable insights to what's working, what's not working, and it really allows us to sort of demonstrate the full value of adopting these automated processes and understand where we are in adoption and really target our efforts for outreach and awareness. As we know where adoption is lagging, we can create targeted initiatives to be able to engage and create innovative solutions to be able to engage both healthcare providers and plans to be able to further drive adoption. Also want to point out that we really need more granular data to fully explore the correlations between the increased adoption that we see and the corresponding declines or stable volumes of manual processes. And so we at CAQH are committed to working with our participants and our respondents to both of the surveys to be able to further drill down into the information. We work throughout the year as the index is in its cycle to be able to further understand how much detail we can do and what we project forward and what can we model to be able to understand and predict what we might expect to see in future years. So future outlook or future enhancements to the CAQH index. The index will continue to monitor industry progress. We are on an annual cycle and look forward to receiving your input and working with our industry stakeholders and partners as we continue to evolve and enhance the index to really meet the needs of the industry as well as to be have the highest capacity and be very much robust. Some specific goals that we have that I think we're worth mentioning today is that we will continue to expand the number of health plans as well as healthcare providers that are participating in the survey. We are working actively to acquire and work with our partners at CMS to be able to have current and comparable data on adoption and utilization of the transactions from the Medicare program, and we're actively working with them and looking forward to, in the 2016 report, being able to have some very nice comparisons to see how progress is being made for the complete industry, health industry. And lastly, we are continually working to improve the precision of our cost estimates. And so we're working to not only assess, for example, for our providers, the labor costs, but we're really working directly to assess and get a more comprehensive picture of the indirect costs, including vendor fees that are variable across the transactions, and understand some of the a more specific or detailed impact of those fees versus the utilization of sort of the loading factor that we use at this point to be able to include those components to our cost estimates. So finally, before we get to questions and answers, I would love to just take this opportunity to just open the door for everyone on the phone to be engaged in the index, as there is huge opportunity here for folks, both health plans as well as healthcare providers, to participate. We will be beginning our next cycle of the 2016 index, which will be collecting data based on the calendar year 2015 very, very soon. We anticipate our call for data submissions, and we'll be hosting public webinars in the month of May. And if you would like to participate or would like more information about the index, my contact information is listed here. You can also go to our website at caqhindex.org. There's also, I'll highlight that there's truly an opportunity for vendors as well. We're looking forward to creating a vendor cost survey for the 2016 index, as well as working with vendors to work directly with your customers to be able to have them be engaged with the index to be able to provide additional information and complete the survey in time ahead. And just so you know, all of our participants, both healthcare providers and health plans, receive a benchmark report, which we have heard reports of how helpful and beneficial they are to the companies that are actually participating, and we look forward to providing those as well as receiving active feedback from the participants and the index both the healthcare providers as well as the plans. So at this time, I think we have just about 10 minutes left. And so I am happy to announce that the 2015 index report is available on the website, CAQHindex.org. For download, it's free of charge and no cost. We're happy to answer any questions. There's a way to contact myself listed in this PowerPoint. We'll also be providing a copy of these slides on the website, and it will be available to everyone that participated. There's also, as Karen mentioned, a recording of the webinar that will be available to all participants. And before we go to questions, I just would like to say thank you to everyone that's tuned in today, listening to us present our findings that we're very excited about. And I think we have a few questions from the original registration page as well as that have come in through the panel. And then we'll open the lines up after that for any one that would like to chime in and ask a question. Okay, so we're handing questions off here. So the first question that we have is CMS engaged in the index, and do we have plans to include public peers? The answer to the question is yes. I've already answered. I think that we are working directly with CMS to not necessarily integrate their estimates into the estimates, but we want to have sort of comparable numbers to be able to compare, because obviously there are complexities in how the programs are administered compared to the commercial space. Another question we have here is, are there differences in adoption rates by plans? Yes, this is true. We actually do have, there is a variation in adoption across the plans that report. And as we've reported in previous years, the adoption variation can be pretty dramatic depending on the transaction. But one of the things that we'll make available in the future in some of our public materials is whether or not there are, what the adoption ranges are across the plans. It does vary across the transactions. For some of the transactions like claim submissions, there's very little variance, but other transactions like prior authorization, their variance can be pretty extreme. But the plans do receive this information in their benchmark reports, and it's available to them. They're able to compare themselves to both other plans as well as the industry averages for each of the transactions. Right, next question we have, why such low rates for COB and what are the obstacles? I'll let, go ahead and answer.
Yeah, so two things. One reminder that this is actually integrating the COB into the transaction where it belongs, not after the fact. So a lot of what's happening now with COB is the cleanup. You don't get the information beforehand and then you clean it up afterwards. So we're trying to track the integration where it should be within the information flow. And I know a number of entities are working on integrating it up front. This is 2014 data. Just a reminder, we're in 2016. This is 2014 data because the study happened in 2015, retrospective data. So it'll be very interesting to see within the 2015 data, does this change because of some industry effort? And then separately, we also are looking at, I think you've seen, there is a COB Smart utility through CAQH, and it has over nearly 140 million lives. We're looking to see within that data if there's anything that can be reported in aggregate that can be compared with this. And if there's anyone out there that does have, again, we're making a call for participants for next year. If you are doing a lot of COB or you're seeing none, and you could either participate as a health plan or as a provider, or if you're a vendor and you have providers that you would like to have participate and we could work with them directly, that would be fantastic. So just forward that along. I know there are questions that we've seen on the write-in about how many of the payers are participating in COB Smart. It's actually growing. It's almost all the CAQH member plans and a number of non-CAQH member plans. And if you go to the CAQH website, there's a listing of the health plans that participate in COB Smart, or you can email Raynard and he will forward you to the right person to get the whole detailed listing.
Great. So I'll keep the questions moving because we have quite a few questions coming in. The next one is, what efforts are being made to better understand the adoption of EDI attachments including ways to increase use and related cost savings. So as I mentioned earlier, the index continues to work to collect information about claim as well as prior authorization attachments. Our current data that we have, similar to the enrollment, disenrollment, and premium payment transactions, is only from a subset of the plans. And so for the annual report, we don't report out in detail because we really try to maintain the privacy of our participants and our respondents. But I can tell you that our current data suggests that you know, really the X12 standard for the attachments are not being used very often. We have, of the plans that are reporting, there's only one single plan that actually has reported providers submitting claim attachments electronically using the X12 standard. So we continue to work on our ability to report out in the aggregate. Obviously, with having a single provider using the plan reporting use of the standard, it's difficult to provide details there. Additionally, CAQH Core is actively working on the issue. We hosted public calls about a year and a half ago on the issue with the EDI attachments, and there's a plan for a pilot for this coming year. And I would also maybe suggest that there are some testimonies from the recent NCVHS hearing that you might consider, and I think they're posted publicly on the NCVHS website, and we're happy to provide a link to it if you would just email us. We're happy to do so. That has some testimony about the issue of EDI attachments. Okay, next question. Are the major vendors and practice management systems contributing to the speed of adoption, especially for dentists? You want to?
You know, many in the industry have commented about the need to engage the practice management systems more into the process. I know within industry findings, whether it's public reports and CVHS, you know, within core certification, we are seeing that some providers that work with their practice management systems and actually ask for the upgrades, they can absolutely get them, but then they need to know to ask. So it may be that the provider is working with a version of the practice management system that's not upgraded, so they just are not getting access to the new information that's available or the new things like real-time claim status. We've had one large health system, multi-billion system, that was the case for them. So more outreach does need to happen with the practice management systems. I know we had staff yesterday attending a practice management system meeting specifically about this issue. And I know many in the practice management system community are committed to this. So if you're out there, you're a provider, and you're not getting access to this, please give us a ring. Or if you're a practice management system that would like to show how you've integrated, let us know. And there was some questions about cloud-based products also. And for those entities on a vendor side, whether you're a clearinghouse or a practice management system, some of them are moving to cloud-based products and getting that ongoing update integrated into the system so there is no version. And we're hearing that is making a really big difference within the community if the entity is committing to being compliant with the mandates, whether they are HIPAA covered or not, and that there's no version, so the updates are constantly coming out. So more to do there, and if there's anyone on the phone that either works with a practice management system or is one that wants to help, let us know.
Great. So we're going to keep it moving because we have a long line of questions. So the first one I'll go with is pretty easy. Is do you have cost estimates for the 278 standard? We do collect for just the prior authorization usage of the 278. And that we showed that in the estimates there, so that's what those reflect. So you can use those as you make estimations regarding use of prior authorizations. We have another question about prior authorizations and what's being done for prior authorizations, and what's being done to fix the low adoption, and when are the what's going on with the mandates for the prior 275. Standards. And I'll let Gwen sort of talk about what we have going on with the prior authorizations and referrals.
Yes, two things. One is within CORE, which is the operating rule author for boasts all the transactions. There's a new set of operating rules out for prior authorization. They're all infrastructure-based, meaning focus on how the data flows between the trading partners, which is a huge challenge for prior authorization. And that is actually, the rules are out, and there's a certification site coming out in the summer. We already have beta and alpha testers that have volunteered for that. So you're going to start seeing entities publicly committing that they're following those rules. Separately, and this was always the vision, is that the next step is working on operating rules that are focused on the data content. There's a multi-stakeholder core board, and they have said now that the rules are done for phase 4, they want an immediate focus on the data content. So simultaneously, while the industry is implementing the rules throughout the market, they can develop the data content that then can flow through the infrastructure. And I know there's others working on this important initiative, so if you want to participate, please let us know. Definitely work on the initial adoption of those new operating rules, because it can highlight those that have best practices, and you can present on education sessions to show how you are using the standard and the operating rules.
Great, thank you. So we'll take 2 more questions that have been typed in. It's a long list, and we apologize if we can't get to all of them. The first one I'll respond to is when cost per transaction estimates are calculated for claim remittance, is it per claim cost or per remittance? And the cost is estimated per remittance, so it's not per claim cost. So we basically use the total number of transactions. There's more detail in the report about how the estimates are actually produced, but even for the health plans where we know, for example, claims are paid, multiple claims can be paid on a single manual check. We're counting the number of checks, not the number of claims that are attached to that particular check. So that's the metric we use there. Along the lines of payment, we have a question about virtual cards and if they impact the adoption of EFT. And I think I'll say, yeah, we do believe that there's probably some impact for virtual cards on the adoption of adoption estimates of EFT. While the index has not reported use of virtual cards, we are currently working with our data contributors to collect data on the use, and we really hope to report some additional details in 2016. That said, we are aware that they are being used. We have gotten some reports from plans of use and some volume estimates. And so we do think it likely impacts EFT adoption. From a CAQH perspective, I would just add that we have worked with NACHA and coordinated with them to be able to, in their efforts to obviously increase awareness and drive adoption of the HHS adopted standard, ACH standard, as well as we also work on EFT through our solution called Enroll Hub, as Gwen described earlier, where we're working to get healthcare providers enrolled into EFT solutions. So I think that in general, we are continuing to work in this area and try to understand better how adoption is moving.
Yeah, and just to add to that, if any, there has been cost studies done on the difference between the cost for doing an ACH-based EFT, which is the index tracks, which the operating rules address, and the Enroll Hub support, and the difference between the cost of that and doing a virtual card. If anyone wants that information, we do have that. You can email Reynard. NACHA has done some nice studies on it, and there is a big cost difference for those of you that are providers on the phone.
Great. So,
thank you, Reynard, Gwen, and Elizabeth. That concludes our webinar for today. Again, you will receive a link enabling you to view the webinar or share it with your colleagues, along with a copy of the slides, which will be available along with the full report at www.caqhindex.org. And if you have other questions that weren't answered today, Reynard's email information is also available at that URL. He'll be happy to route your question to the appropriate person within our organization. On behalf of my colleagues at CAQH, thank you and goodbye.